Welcome to Inflammation Nation. My name is Gráinne O'Leary. Inflammation Nation is a podcast from Arthritis Ireland aimed at increasing awareness and understanding of arthritis and related conditions. You're very welcome to the first episode of Inflammation Nation. Today I'm joined by Professor Oliver FitzGerald and Professor Steve Pennington. Professor Oliver FitzGerald is a consultant rheumatologist and Newman Clinical Research Professor in the School of Medicine and at the Conway Institute, UCD. Professor Steve Pennington is a Professor of Proteomics in the School of Medicine and at the Conway Institute in UCD. Delighted to have you both here with me today. Thank you for giving your time. Oliver, if I might start with you, we're looking at this whole area of psoriatic arthritis today. So can I start with the most basic question, like what is psoriatic arthritis and how does it differ to other forms of inflammatory arthritis, like, for example, rheumatoid arthritis?
Thanks, Gráinne. Delighted to be here this afternoon to talk with you about psoriatic arthritis. So psoriatic arthritis is a form of arthritis that occurs in patients who have the skin rash psoriasis. Psoriasis is a very common skin rash, and it's usually takes the form of scaly patches on the skin, and it's found in up to 2 to 3% of the population have the skin rash psoriasis. And what we know is that about 30% of patients with psoriasis may also develop an inflammatory arthritis that can involve any of the joints, and it can also involve other parts of the musculoskeletal system, including where tendons are attached to bone. It can cause inflammation of a whole digit, and we call that dactylitis. And it can sometimes also involve the spine. It differs from other forms of arthritis, like rheumatoid arthritis, in that rheumatoid generally doesn't involve the spine. It doesn't cause this swelling of the digit or dactylitis. And it usually doesn't involve areas of attachment of ligament to bone, like where, for example, your Achilles tendon is attached to the back of your heel. It's similar in that when a joint is involved, the individual joint may look like inflammation in any other cause, may not be different, but it does have these clinical differences, these other features that tend to help us in making the diagnosis of psoriatic arthritis.
Okay, and what would be the main symptoms that somebody might experience?
Well, early on in the disease, patients will complain mainly of joint pain and stiffness. Fatigue would be the main symptoms. As the disease progresses, you may get other features apart from joint pain. The joint may also be visibly swollen. It may be tender to touch. You may have other features then developing. You may get this swelling of a digit, like a sausage. So we call it a sausage digit or dactylitis. Commonly affects the toes more than the fingers, but can affect both. And you may get pain or inflammation at the site of attachment of ligament to bone. So, as mentioned, you may get somebody complaining of pain in the back of their heel or in the undersurface of their heel would be common sites of involvement. Furthermore, patients may complain of back pain and stiffness, commonly in the lower back, but also the neck and other parts of the spine can be involved as well.
Okay, and in terms of, the causes of it, do we know what causes it?
Well, I suppose the bottom line is we don't know exactly what causes it, but we've learnt a lot about the disease psoriatic arthritis over recent years. And we know that if you have psoriasis, that there are certain features of the psoriasis, for example, that are found more commonly in patients who have psoriatic arthritis. And that would include things like the location of your psoriasis. So if you have scalp psoriasis, or if you have psoriasis in the groin or underneath the armpit, that those sites of involvement are more commonly found in patients who have psoriatic arthritis. Also, if you have nail changes, so nail changes are certainly more common in patients who have arthritis. We don't know why, but it's one of the risk factors, if you like, or person factors that are associated with the development of psoriatic arthritis. Then there are genetic factors. So one of the things we've learned over the years is that psoriatic arthritis occurs much more commonly in families where psoriatic arthritis is already present. And that all comes down to genetics. And there are certain genes that do appear to be present much more commonly in patients with psoriatic arthritis than in patients with psoriasis, or then in patients who don't have arthritis or psoriasis. So these genes include genes like HLA-B27, and it's been found to be commonly found in patients with psoriatic arthritis, and appears to define a certain type of psoriatic arthritis. So that patient who has HLA-B27 tends to have more spinal involvement and tends to have more inflammation at the sites of attachment of ligament to bone as well. There are likely environmental factors then that may trigger the disease, and we know that changes in the gut microbiome, or the bugs that are inside your gut, may be associated with onset of psoriatic arthritis. There are data that suggests that experience of trauma may trigger psoriatic arthritis. And we know that psoriatic arthritis is also more common in patients who are overweight or who may consume excess amounts of alcohol. So all of those may act as triggers to the development of the condition.
So lots of things to consider, really, when
Lots of
you're
things
looking
to
at
consider.
causes.
Yeah.
How does it impact upon a person's life?
It can have a very significant impact on a person's life if the disease is not diagnosed early and treated early. It can affect physical function, and that in turn can have an effect on all the various activities that one would like to get involved in, including work, leisure, and family life. All can be affected by bad psoriatic arthritis. It can also affect your mental health, and having depression, for example, would not be uncommon in patients who have psoriatic arthritis. So it can have a very significant impact on a patient's ability to run a routine, normal life.
So if we move on to, the treatment for this disease, how is it treated, and how has that evolved over the last couple of decades? Because I know there have been significant developments in how this disease is treated.
Yeah, very fortunately, the last, 15 years has seen the development of multiple new treatments for patients with psoriasis and psoriatic arthritis. And in particular, I guess, for the skin component of disease, some of the newer treatments are very effective. For joint disease, there certainly have been major improvements as well, but perhaps not to the same extent as for the skin involvement. We don't know why that is, but it's one of the observations. So there have been several new treatments. These treatments are targeting cytokines or proteins that we know are present in the blood of patients who have psoriasis and psoriatic arthritis. They're also present in the involved skin or joint tissue, and they appear to be driving the inflammation in those joints. So these treatments have been developed to target these proteins or cytokines individually. So some of these drugs, the names would be well known. They would target agents like cytokines like TNF. Interleukin-17 is another group of medications that have been developed. And these new treatments continue to be developed. So lots of improvements, but there still is an unmet need there because, unfortunately, not everybody responds to these treatments.
And why, what exactly would those unmet needs be?
I think there are several unmet needs within psoriatic arthritis. Firstly, psoriatic arthritis can be difficult to diagnose.
Why exactly is that?
Well, there's no test for psoriatic arthritis. With rheumatoid arthritis, you can run a particular blood test called rheumatoid factor or CCP antibody. And if a patient has strongly positive rheumatoid factor and CCP antibody, you can, it certainly increases the chances of that patient having rheumatoid arthritis. But that isn't the case with psoriatic arthritis. There's no blood test that you can run for psoriatic arthritis. The diagnosis is based on basically the assessment made by the doctor or healthcare professional who's examining you. And it will depend on their experience and expertise as to whether or not they're able to pick up the diagnosis. Many will, of course, but it can be quite subtle. It can be difficult to diagnose. So one of the unmet needs is to develop a diagnostic test. So if we could have a diagnostic test that would allow the disease to be diagnosed early, I think it could substantially improve the early introduction of, to improve the chances of the early introduction of treatment for patients with psoriatic arthritis. So that's certainly something that would be high on the list of unmet needs. Mm-hmm. The second unmet need, I guess, is that among all the patients with psoriasis, we're unable to pick out or select out which patients are likely to develop psoriatic arthritis. There are, as mentioned earlier, there are some risk factors which, suggest that this patient may be more at risk, but they're not really specific enough and don't allow us to say with certainty that this patient is going to develop the condition. So it would be great to be able to look at a population of patients who have psoriasis and assess them in such a way that you're able to say this patient is at very high risk of developing psoriatic arthritis. Because then that opens up the possibility that you can potentially prevent that from happening. So it opens up a whole new era, perhaps, of treatment where we would target disease prevention rather than just control of inflammation once the disease has begun. So that would be quite exciting.
Yeah.
The third area of unmet need relates to the whole area of damage. So inflammation in the joints or elsewhere can result in joint damage. And the damage in some patients can be quite severe, such that it interferes with their ability to function normally. Again, in early disease, we're unable to select out which of those patients is going to develop joint damage. So it may be that if you could identify those patients early, that you could introduce appropriate treatment to prevent that damage from occurring. So that would be a major advance and is at present a major unmet need. And I suppose the other unmet need relates to treatment. So as mentioned, we have lots of good treatments, but we really don't know how to use them properly. We've no way of knowing which treatment we should use for which patient. There are some little things that point you towards one direction or towards another direction, but we really don't know which patient is going to respond to which treatment. And therefore, the experience of a lot of patients is that they spend time on one drug, which they find then doesn't work, and then they have to switch to another drug.
And wait the time to see if that works.
Each time, and then to another, and it can go on and on. So if we could identify early which drug the patient is likely to respond to and get the patient started on that drug, I think that would be a significant improvement.
Yeah, and then thereby a huge impact on their quality of life.
Absolutely, yeah.
We're going to take a short break from our conversation with Oliver and Steve to look at popular beliefs about arthritis. In this first instalment of a regular feature, Peter Boyd is exploring a hot topic of conversation: how the weather affects arthritis.
So thanks a million for that introduction, Gráinne. Today we are going to examine the weather and the belief that bad weather brings on more pain, more stiffness and less mobility. In non-COVID times, the clamour for the relief of 2 weeks Mediterranean sun each summer can be deafening. Is there any foundation to the belief that those living with arthritis are indeed human barometers, capable of knowing the weather without a forecast or even opening the curtains in the morning? And it's not just in Ireland that this idea pervades, with rheumatism known as wind-wet disease in Chinese. So, can poor weather give you arthritis and indeed make it worse? This week, our intrepid reporter Niamh Hogan visited the Waterford Greenway to see what you think about the weather and arthritis.
I find that my arthritis is worse in the winter time, particularly when it's very cold. Yes, from listening to people down through the years, I don't have arthritis, but people say that when it's the wet weather and the cold weather affects their arthritis.
Yes, I have heard of arthritis and the weather affecting it. My mother has arthritis in her back, and during the cold weather she would suffer, and always finds a hot bath helps.
Yeah, so I've heard of bad weather bringing on arthritis. I don't know if it's true or not, but it's certainly what my grandparents used to believe when they suffered from arthritis.
Yeah, I believe the Irish weather is not good for arthritis. We need more sunshine to get us away from arthritis, but yes, we're well used to arthritis because of our weather.
Definitely wet, damp, cold weather does affect people, and I know both myself indeed and friends of mine, when we go to warmer places, i.e. to the Canaries or something like that, that you'd be almost pain-free because you have this lovely temperate climate all the time.
Yeah, if it's cold and wet, it would affect your joints, I'd imagine. You get sore joints, I don't know.
Yeah, they might get a little bit stiff.
The cold weather especially, I believe, yeah. I have arthritis in my fingers now, and in the winter time is bad for it, but this weather is great.
So joining me now to discuss these beliefs is consultant rheumatologist in St Vincent's University Hospital in Dublin. It's Professor Doug Veal. Doug, thanks a million for joining us. First off, going by those clips, it's fair to say the belief exists that weather impacts on arthritis across all age groups. Are we more susceptible to arthritis due to our climate here in Ireland?
Hi, Peter. It's a pleasure to be with you today. Well, it's actually one of the common myths is that the weather will adversely impact patients with arthritis. So most people, if you ask them, they'll say, I feel much worse, and the arthritis symptoms are much worse in the cold or damp weather, which, of course, we get a lot of cold, damp weather in Ireland. But actually, when you really drill down into it, what it actually turns out is that some people feel worse in cold and damp weather, and some people actually their symptoms are worse in the hot weather. And it probably depends really on the individual rather than the weather itself. So some people will feel better in the warm weather, some people actually feel their symptoms worse, and likewise in the cold, damp weather.
Okay, and is there any way of seeing that in kind of clinically measurable factors, or would this be more so in self-reported scores that people would complain about pain or explain their pain as feeling more and affected by the weather?
Yeah, it's more reflected in self-reported scores.
Okay.
It's difficult to. I mean, like diet, the weather is difficult to measure the impact on patients specifically. But if you ask the patients, that's what they'll say. And there's a great app actually. A group in Manchester develops an app which they called Rainy with a Chance of Pain, which reflects the how the patient feels in relation to the weather. And they looked at this in some detail, and they found that there was no specific pattern across all patients with arthritis. And so it really does depend on the individual.
Okay, so like I say, not necessarily the 2 weeks on the Mediterranean coast is going to make all the difference in the pain levels for our patients.
No, and so some people they'll say they love it, and some patients will probably feel better in the warm, sunny weather in the Costa del Sol, no matter how active their arthritis is. Certainly I feel much better in the warm weather than I do in the cold, damp weather. But it's very much dependent on the individual.
Well, we appreciate you joining us, Doug, and giving us that insight into it. And I think for the moment we'll carry on living in our damp, wet weather here in Ireland and see how we get on.
Most of us have no option.
Thanks a million, Doug. Really appreciate it.
Thanks, Peter. Now returning to our conversation with Professor Oliver FitzGerald and Professor Steve Pennington. Steve, if I can turn to you now. As Professor of Proteomics, can you tell us about your field of research, first of all, and how it relates to research into psoriatic arthritis?
Yeah, delighted to have the opportunity to do that, Gráinne. So the field of research, proteomics, is really trying to study and understand proteins but at a genome scale. So we know that we have 20 few thousand genes, and they encode proteins, and it's the proteins that drive disease, but can also then be used as measures of disease. So I think many of the listeners will be familiar with an inflammatory protein, C-reactive protein found in blood, and I suppose the field of research that we're in is looking for new proteins that may drive disease but also be indicative of disease, and we call those things that we can measure objectively biomarkers. And so in our case, the biomarkers are proteins, but they can be other things. And to do that on a much bigger scale than had ever been done previously by measuring multiple proteins simultaneously. So I've been really fortunate. So about 10 years ago, Oliver and I got together. He approached me, and I've had the fantastic opportunity of working with him, and obviously then focusing our proteomics efforts in the area of psoriatic arthritis. And I suppose what we've been trying to do is to address some of those unmet needs that Oliver's just identified. And a starting point would be to have a test that could allow us to diagnose psoriatic arthritis. And we've begun the first steps in that, in really trying to develop one that can discriminate patients who might have rheumatoid arthritis compared to those who have psoriatic arthritis. So a sort of a differential diagnosis, because I think Oliver's really clearly indicated that it's a really complex series of clinical manifestations of the disease, and it makes it very difficult, particularly for more junior rheumatologists, to make a definitive diagnosis. So a test would allow them to do that.
And I suppose that leads me on nicely to the new EU research project Hippocrates, which was announced over the summer, which seeks to promote early identification and improve outcomes for patients with psoriatic arthritis. Can you tell us more about that?
Yeah, so Hippocrates has been a long time in the gestation. I think we started talking about it in 2017 and developed a program of research which we applied for funding for. And as you say, the funding of that has just been announced. So it's a public-private partnership between academic institutions, but also some pharmaceutical companies. And the public part of it is funded through an office in the EU called the Innovative Medicines Initiative Office. And then 4 pharmaceutical companies are involved in the consortium. It's 24 million euros in funding. It's a 5-year project. And just over 20 research centres and clinical centres throughout Europe. So a really exciting opportunity, all of it focused on psoriatic arthritis.
And of course Ireland is playing a lead role there as well, which is...
Yeah, so Oliver and I, managed to find ourselves in a position where we led the development of the application, and so the whole project is being led out of UCD.
Fantastic to hear that. And can you tell us a little bit more about the key components of the project?
Yeah, so the project really is an ambitious one, as you'd expect of a project of that scale, and it really seeks to address the unmet needs that Oliver's identified there, the major unmet needs in psoriatic arthritis. And it's as these projects are, it's divided into a series of work packages, and 4 of those work packages are really focused on identifying genes and proteins that might be involved in the first one to allow us to identify patients with psoriatic arthritis. In the second work package, to identify patients with psoriasis who are at high risk of developing psoriatic arthritis, but clearly then you could intervene earlier in those patients. And then to address the other 2 unmet needs that Oliver described, which is identifying those patients who will have joint damage or radiographic damage, and also then being able to predict which patients will respond to which particular treatments. I suppose to try to develop this at the individual level. So this is a sort of a personalised, individualised healthcare medicine approach strategy.
It certainly sounds very exciting because you've very clearly identified those unmet needs that exist out there, and to think that this project seeks to address those unmet needs, I think is really, really fantastic.
Yeah, and I think that Oliver's articulated those, but they're also Oliver is the current president of a group called the Group for Research and Assessment of Psoriasis and Psoriatic Arthritis, the acronym GRAPPA. And it's an international group of dermatologists and rheumatologists with patients involved, and also the pharmaceutical companies. And it's them that have collectively distilled down the identification of those key unmet needs.
Yeah, and if I can maybe ask you, in terms of, obviously at the heart of this is patients with psoriatic arthritis. How ultimately do you see patient involvement How is it incorporated? How is it being incorporated so far, I suppose, into the development of the research project? And how do you see that continuing through the various stages of the project?
Yeah, so I think patient involvement's been key at every stage. So that right at the early stages, so I mentioned back, when we were conceiving the project in 2017, patients were involved in, helping to identify the research that would be undertaken to address the unmet needs and provide their input. They've been involved in the various stages in writing the proposal and submitting the proposal to IMI, the Innovative Medicines Initiative. And now that the project is running, they're involved in all of the work packages. So they're directly involved, on a day-by-day basis in the project as it develops. But also then, in the major sort of organisation and the management of the project, they're involved in that. And there's a small team, the executive team, and there's a patient representative on that executive team as well.
Okay, thank you.
And if I may, just to add that there is Irish involvement in that as well.
Yeah.
So
really good to hear.
One of the patients involved, and in fact the patient who's representing patients on the executive team is an Irish patient, Dennis O'Sullivan, and who's doing a fantastic job. He's also just stepped down as the lead patient research partner within GRAPPA as well. So he's been deeply involved in this over many years.
Really delighted to hear that. And finally, I might turn back to you, Oliver.
Sure.
Ultimately, how is this project, how do you believe it might impact the lives of people living with psoriatic arthritis?
Well, I would be very hopeful that at the end of this project, which is going to go on for 5 years, that we will have developed a test. Now, that may need to be validated in much larger numbers of patients. But we will have got to the point that we'll have a test to validate that will help us diagnose the condition early. That in turn will allow us to introduce appropriate treatments at an early stage. And I would hope that through the work in Work Package 4 in particular and other work packages that we'll be able to identify which treatment is going to be the most appropriate for which patient, so that we'll be treating our patients in a much more clever way than the way in which we currently treat them, where as mentioned earlier, it's we don't have a good way of knowing which is the best treatment for our patients. So I would hope that will ultimately improve outcome, prevent damage, and maintain patients' function into the future.
Oliver FitzGerald, Steve Pennington, thank you very much for joining us today.
Thanks, Gráinne.
Appreciate your time. That's all from this episode of Inflammation Nation. Don't forget to subscribe on Apple Podcasts, Spotify, or wherever you get your podcasts. For further information about arthritis, you can visit our website, arthritisireland.ie, or contact our helpline on 0818 252 846. See you next time. Inflammation Nation is supported by Pfizer.